So good morning, good afternoon, and good evening, everyone. And thank you for joining us today for our MendingKids Symposium on Post-Procedural Care of Complex Congenital Heart Disease. This is our second symposium, and we'd like to welcome you all. I'd also like to thank our board member, Dr. Evan Zahn, Congenital Heart Program Director and the Director of Division of Pediatric Cardiology at Cedars-Sinai, for hosting, and Dr. Darren Berman, who's the co-director of cardiac catheterization and interventional therapy in the Heart Center at Nationwide Children's Hospital in Ohio. Our two doctors will be co-hosting today's symposium, and I will also like to acknowledge the Jakaya Kikwete Cardiac Institute and Professor Janabi and Dr. Naiz Majani for helping us coordinate this event, and to the Edwards Life Science Foundation for sponsoring this event as well. So thank you, and Dr. Zahn and Dr. Berman, I cede to you.
Great, thank you, Isabel, and thanks to MendingKids and Edwards Life Sciences for helping organize and underwrite this this conference. We had a really successful first meeting, and we've lined up a tremendous speaker lineup today to talk about post-operative issues that you all encounter in the ICU. Before we get started, we just wanted to send a shout out to our friends in Dar es Salaam at JKI. I brought Phil. Phil's a crowd favorite in Tanzania, so I stole him out of the cath lab just to say hi to everybody. He does, as everybody knows over there, a ton on all our missions to keep that going. And we look forward to coming back. And with that, I'm going to turn it over to Dr. Darren Berman for a few words. Darren?
Thanks, Evan. I'd like to second everything that Evan Zahn just said, and I'm really excited about the second symposium. Would really like to welcome back all of those that were able to attend the first. We hope this is as successful or even more successful than the first. And for anyone who's attending for the first time, welcome. We're excited for the lineup. I'd like to thank all of the speakers who have graciously agreed to provide us some of their time and put together what's going to be some excellent talks. And I think with that, I think we should get started. Evan, you want to introduce?
Yeah, I'll start with the introductions, but before I do, just a few ground rules for everybody. One of the reasons we were so successful, I think, with the first meeting is we had tremendous interaction from all of you out there in the audience, just really good exchange. So you can see that the host has muted you so we can have clear presentations, but please type your questions and your comments in the chat box, and then Darren and I's really only function today, other than introducing our much brighter colleagues, are to moderate those questions and facilitate a discussion. So we really look forward to interaction with all of our colleagues from over in Africa. So please don't hesitate to type anything you like in that chat box, and we will make sure we get it to the right speakers. And with that, I'd like to kick us off by introducing our first speaker, who I go way back with. Ruby Whalen works at Nicklaus Children's Hospital in Miami and is singularly one of the finest nurses I have ever had the privilege of working with. Ruby's career spans pediatric intensive care, cardiac intensive care, cardiac cath lab, cardiac research nurse, and now back in the cardiac intensive care, all at one children's hospital over a long period of time. She has a ton of experience and is a wonderful educator, and it's a real thrill to have Ruby join us. And thank you so much, Ruby, for taking the time out of your busy schedule. And Ruby is going to talk to us about what we gave her, which is not an easy topic, 10 commandments of post-operative care of complex congenital heart disease. And with that, I'll turn it over to Ruby Whalen. You just have to unmute.
Can everybody hear me?
Perfect.
Okay, so thank you, Evan and Darren, for this wonderful opportunity. I'm going to share my screen now. As Evan said, I was asked to talk about the 10 commandments of post-op care, and the only disclaimer I'm going to have is that I am a nurse educator, so I'm going to come at it from that perspective. So the next 10 minutes will be heavily on nursing. And let's share my screen. All right, can everybody see?
Looks great, Ruby. We just need it in presentation mode, but the slides look really clear.
Okay,
Perfect.
ready? All right, so the objective of this presentation will be to provide an overview of the components of post-op cardiac patient care. And to do this and to outline these 10 commandments, I actually asked a lot of my colleagues. So I asked our bedside nurses, I asked respiratory therapists, I asked our nurse practitioners and some of our attendings as well, what they thought some of the important points to touch on would be today. So this is just an overview of the 10 commandments that we outlined, and I'll go into detail with these now. The first thing that we said was to have a plan. So with any post-op patient, you want to be able to anticipate the post-op course, no matter if you're a nurse or a physician or whatever role you're playing in the unit. So if you're a nurse, for instance, and you know that this patient is going to come out complicated or may have a longer post-op period, as you're setting up your room, you may want to think about, do I have an appropriate bed service for this patient? Is this patient going to be immobilized for a long time and run the risk of skin breakdown and infection on top of a complex congenital heart surgery? So anticipate the post-op course and have a plan so that you can prepare for all of these things. So your bed surface, your room, your potential complications. Do you need to have more medications on hand? Do you need to have more supplies on hand? Do you have the right staffing mix of seasoned and maybe not so seasoned nurses and nurse practitioners? Because really the goal should be that when the patient comes into the room, you want to be able to minimize the activity. So you want to be able to have as much as you can ready to be used. The other commandment was communication. So we have a pretty big unit at Nicklaus Children's. It's about the size of an American football field, they tell me. I don't know, I've never watched a football game, but that's another story. So we could be anywhere in the unit. So having pre and intra and post-op communication with our interdisciplinary team is so very vital. We know what's going on in the OR basically as it's happening. We can see the vital signs and the monitors of the patient that's in surgery as well. And the surgical nurse practitioners are wonderful at keeping us up to date and making sure that we have all the information we need as well. We do a team huddle, so about 5 minutes before the patient rolls out of the OR, as a team, the nurses, respiratory therapists, nurse practitioners, everybody that's going to be taking care of that patient huddle in one room, and we talk about what to anticipate when the patient comes. And then we have a standardized OR handoff tool as well that I'll share in a moment. Another thing we do, because again, it's a really big unit and we can be anywhere there, is our unit secretary announces that the patient's coming. So the minute the OR team rolls into the unit, overhead, you'll hear that the post-op patient is in the house basically. And then we can all get into that room at the appropriate time. So standardized communication, I think, is really important for patient safety as well as for our team's preparation. And so we do have a standardized patient post-op checklist and also a standardized OR to CICU handoff that the team fills out and brings ahead of time to us. The other commandment is to have an organized process. No matter what, you want to minimize any disorganization or second guessing around bringing that patient out of the OR. So the goal should be to standardize your information, to standardize the roles of the people in the room, and to minimize crosstalk and activity during OR handoff. And what we've done is we've initiated something called the pit crew. Again, sort of based on racing sports, a quick in and out, but this diagram kind of shows you. So this would be our patient, and all around you can see where the equipment is, the IV poles and the monitor, but you can also see where each person should be in relation to that patient's bed. The nurse, of course, is usually at the head, transferring over the equipment and assessing the lines, and everybody else is around, and everybody has a role and a place to stand in that room when the patient comes in. The fourth commandment would be clinical pathways. So again, clinical pathways are really just to set expectations and goals for care so that we're all on the same page. It provides a unified vision across the team of the expected post-op course. Because as you can see, sometimes, and I know you well know this, sometimes things can get a little complicated. There can be a lot of different team members involved, and with every team member, you can get a different story of what you should be doing. So we use pathways to try and minimize any deviations or any confusion. This is what one of ours looks like, and I want to thank Dr. June Sasaki for letting me share this here today. So for our clinical pathways, this is the one for the tetralogy of Fallot in an infant. So down here you can see the post-op days, so the day of surgery, post-op day 1, 2, 3, and here is where we would want the patient in a perfect scenario where we'd want that trajectory to be. So we would hope that the patient would come out extubated, but it's okay if they're not, but hopefully by post-op day 1 or 2 they are. And then we move along, we continue sedation for at least a couple of days on the patient, continuous sedation. We would hope that by day 2, certainly by day 3, the Foley would be out, and the same, you know, for the milrinone. So this is kind of how we use our clinical pathways. And to get there, of course, we have protocols. So along with the clinical pathway for tetralogy of Fallot, we would have this posted up in the room too. And it really just, again, provides an algorithm for everybody, for the nurse and for everybody on what we would expect in a perfect world for this patient's post-op course to be. For some patients that are high risk, we also use a resuscitation action plan. So this one is for mostly for our single ventricle neonates, and it just kind of tells you why this patient is high risk, what the preventative measures could be, what our code medications and doses would be, what equipment we should have in the room or just outside of the room, and sort of what the vital signs, etc., would be. So this would be posted in the room as well for eligible patients. And that's what this looks like. So, sorry, we would have the clinical pathway and the resuscitation action plan. Actually, I took this picture yesterday. It was posted in a patient's room. Outside of our door, as you can see from here, this tells us that this patient is high risk. So even before you go in the room, you would know that. And because the patient is high risk, the nurse would have resuscitation medications nearby. So instead of using a full code blue cart, we use something called a heart box, and that's individualized to each patient, and it's prepared by pharmacy, and pharmacy handles the expiration, etc., of the medications. But this would be in the patient's room at the bedside. And as you can see, because the action plan here calls for some medications to be drawn up in the immediate post-op period, the nurse does have some of her medications drawn up there. The other thing, again, you know, standardizing communication is a big patient safety issue. And so we do that also through checklists and resources for our staff, for the staff. So this is just an example of, you know, an ET tube taping protocol. But we champion a lot of nurse-driven protocols as well in our post-op patients. So electrolyte replacement, there's a standing protocol for that. So if the potassium is low or magnesium is low, the nurse can replace it up to a certain point to get the potassium to where it needs to be without having to consult with the medical team. The state behavior score we use for all of our all intubated patients, so that sort of standardizes the language around how sedated the patient is. So if the nurse says in rounds, well, the state behavior score is 0 to 1, but the goal is for -1, that tells everybody on the team that the patient is more awake than we would want the patient to be at that time. So here's just some of our standardized protocols that we use too for our post-operative patients, and most of these are nurse-driven. We could talk forever about comfort, sedation, and withdrawal, but I won't. But here's just some of the things that would be important as well for your post-op patient. So, you know, measuring pain and assessing and treating it as well. Daily sedation interruptions, weaning protocols. So again, safety for post-op patients is often about standardizing care and standardizing communication and protocols. This is just a schematic of what some of our sedation protocols would look like. This is for the state behavior score. Again, this would be, of course, for sedated patients. And over here we would have, and this one is actually nurse-driven as well. So if the goal is, if the patient is more awake than the goal is, then that nurse would automatically just administer the sedation without having to inform the team. So that also has helped us reduce unplanned extubations dramatically as well over the past 2 years. And this is just an algorithm again for what a sedation protocol looks like as well. Everybody said we have to talk about access, access, access. So we do. There's a lot of things going on in an average post-op patient's room. So everybody should know what's infusing, where it's infusing. More nurses said yesterday, more lines is best. So for all you physicians out there that are putting in lines, they say we can never have too many, especially if the patient's going to be sick. A few days later, you might want to think about, do you need that central line? There is a risk of infection with central lines. Can we convert to a PICC or a peripheral IV as well? So this is a quality indicator that the bedside nurse can really champion and advocate for the patients as well. But access, 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 I'm told, is very important. The 9th one would be, somewhere in all of this is somebody's child. There's a baby or a toddler in the midst of all of the equipment and everything else we're doing. We know there's a lot of literature out there now that talks about developmental care for our children, especially for the neonates. So just to keep that in mind, even if it's post-op day 1, we can be looking at, are we positioning properly? Are we keeping our arms and legs midline, or are we sprawled out like little baby frogs? So we also encourage our parents at this point to come and read to the baby, and if they can't come, then to record their voice so we can have that for the children as well. So developmental care and family-centered care is very important also in post-op care, and I know in the busyness of life that sometimes gets overlooked. The other thing is, if you're going to have a good post-op outcomes, you need a good team. So the only way to do that is education and support. We've standardized our post-op orientation period, so the nurse has to be in the unit for at least 12 months and meet certain indicators before we take them out of the schedule and put them into the 3 to 4 week post-op orientation process that they would have. In the time of COVID, it's been very challenging with education as well, but we've moved, just as you are, I see, to a lot of Zoom calls and Zoom technology as well for formal and informal. So here's one every second week. We do an informal heart talk, a 15 to 20 minute talk by Zoom. And last week, one of our nurse practitioners, or actually tomorrow, one of our nurse practitioners is going to give it on basic safety checks, because we do have a lot of new nurses. About 52% of them have less than 2 years of experience. So ongoing education is very, very important for any members of our team. I would encourage everybody, if you haven't, to take a look at the PICS handbook, and also for the nurses out there to take a look at this article too. We use that one as a very guiding principle for a lot of our post-op training and education. The other thing is, in the time, I just want to touch on this one last thing. In the time of COVID, you know, simulation labs have been very difficult for us because, again, you know, social distancing and managing crowd control. So we moved to in-unit simulations for mock codes and just basic simulations as well. And how we did that was we moved to a mobile technology. We use something called the Dart Sim app. It's very inexpensive. You can download the app for less than $50. And then you would, we downloaded it onto an iPad. We use Apple TV, and as you can see, there's the iPad and the scenario is there. So then you can use a basic mannequin instead of a high fidelity one and do your mock codes for training. This is so easy for us that we do some sort of scenario every week because it's really just a mannequin and an iPad and an empty room. So instead of having to plan ahead for simulation labs, I just go in and set up the room, and whoever I look around, and whoever's not too busy, I just tap them on the shoulder and say, let's come play. And actually, all of our staff, the fellows, are involved in this, as well as our respiratory therapists and care assistants and nurses. But just putting that out there, because good post-op care needs a good team and good education as well. So that should be one of our 10 commandments as well. And that's it. If you have any questions, please feel free to let me know. And thank you all so much for your time and attention.
Great. Thank you, Ruby. That was a wonderful talk and overview. And I think, you know, as most of us would agree, I'm sure having a talk geared to our ICU nursing and nursing staff and ancillary staff, as well as the physicians, is critically important. They play such an important role. We don't have any questions just yet. We'll certainly leave time at the end of the session for more discussion. So if there's nothing pressing, we'll try and grab a little time here, and I'm going to move on to the next talk. The next talk is given by my partner, colleague, and friend, Pooja Nawathe. Pooja is a pediatric critical care intensivist here at Cedars-Sinai Medical Center within the congenital heart program, with her specialty being care of critically ill children and infants with congenital heart disease. And it's a real pleasure to have you speak to us today, Pooja. Pooja's topic is respiratory strategies following congenital heart surgery, and I'll turn it over to Pooja.
Can you guys hear me?
Yes.
Perfect. So good morning, good afternoon, good evening for all the continents and countries. And it's a privilege to be here. Thank you, Dr. Berman and Dr. Zahn, for inviting me. I am going to now share my screen. Just bear with me. Hold on, sorry. Let's see, share screen. Okay. Okay.
Great, Pooja. We see it.
Do you see it in the presenter view, or do you see my screen?
We see it in kind of well, we had the presentation view for a second, but then it went to, now I don't have it anymore.
Okay, how about now?
Yeah, that's the one. Perfect.
Okay. All right. Thank you for having me do this talk. My email is on the slide along with my Twitter handle in case some of your questions don't get answered during the talk. So because this is such a vast topic, I am going to sort of categorize it into domains and goals rather than doing it individually for each structural heart defect. So when we think about respiratory strategies following congenital heart disease, think of it as, let's see, okay. We think of it as what are your goals when you think of respiratory support following congenital heart surgery? So there are two primary goals. One is to optimize oxygen delivery, and one is to improve CO2 elimination. Optimizing oxygen delivery is always thinking of it as a balance between optimizing delivery and decreasing demand. And the demand in respiratory failure after heart surgery is mostly metabolic demands of your respiratory muscles with increased work of breathing. These are the two big goals in any patient after a complex congenital heart surgery. You think of it as meeting the needs of the patient. So depending on the specific anatomic, structural, or physiological heart defect of your patient, with maximum benefits and lowest risk of complications. The next slide is going to be talking about pulmonary mechanics of respiratory failure in a patient with congenital heart surgery. And the big two things to remember, and there are many things, but alterations in intrathoracic pressures are transmitted to cardiac structures. Very profound in neonates and smaller infants, because transmural pressure, as we all know, is related to intracardiac pressure and pleural pressure, and intracardiac pressure in infants and neonates is pretty small. So any little change in intrathoracic pressure has significant effect on transmural pressure. So the profound effect on cardiac structures is seen in this category of patients. Increased pulmonary blood flow in patients with intracardiac shunts is important, as it does increase airway resistance and decreases compliance. This is one of the holy grail sort of graphs of cardiac critical care. And what's important to know is x-axis is lung volumes, y-axis is pulmonary vascular resistance. When you have complete collapse, your lung volumes are not optimal and they're at the residual volume range. Maximum expansion is TLC, which is total lung capacity. What's key to remember is that your PVR is the lowest, not when you're underexpanded, not when you're overexpanded, but when your lung volume is at FRC, which is functional residual capacity. So this is really key. At a given point in a patient, PVR depends on the sum of all these. And what your aim as for respiratory management is you want your PVR to be lowest, because that's when your lung volume is at FRC. So what does positive pressure ventilation do to what are the cardiopulmonary interactions of note? So positive pressure ventilation, and by this, it doesn't necessarily mean endotracheal intubation only. This is also significant to bag mask valve ventilation, is decreases RV preload, increases RV afterload. Because of interventricular dependence and decreasing RV preload, LV preload decreases, and LV afterload decrease is probably the only good sort of cardiopulmonary interaction which can be used as a benefit in our complex congenital heart disease patients. So as Ruby very aptly said, pediatric cardiac intensive care is a team sport. And respiratory care in the cardiac intensive unit should be thought of as a continuum of care from the operating room, right? And each of these team members play an integral part on what you think of as the team taking care of these patients in the PICU. So this is our, back to her 10th commandment, this is our education part. It's an in situ simulation with a high fidelity mannequin. We have the cardiac surgeon who tells us what happens in the OR with the times and the bypass times and the structural anatomy. The anesthesiologist who tells us what happened with the airway, how was the patient to ventilate. The cardiologist who gives us very key information about post-op TE and any evidence of ventricular dysfunction. You have the respiratory therapist who's going to be there at the bedside, the cardiac intensivist, and the nurse. And there are more nurses which you don't see, but these are all part of the team sport of cardiac intensive care. So as a goal for any patient after congenital heart surgery, early extubation is definitely beneficial. So many centers in the United States, depending on the ergonomics of where the ICU is situated as compared to the operating room, will extubate these patients in the OR for a simple congenital cardiac surgery. There are many clinical benefits, but one has to be aware that in certain patient populations, such as younger infants, because of higher risk of airway edema, cardiac dysfunction, or pulmonary disease, the risk of extubation failure may be higher. Special considerations, obviously open chest, not an early extubation candidate. Trisomy 21, the longer the patient is intubated, the longer the risk of upper airway obstruction. And sorry, it's going faster. And then Fontan procedures, spontaneous or cavopulmonary anastomosis, spontaneous ventilation is key because your cardiac output depends on passive pulmonary blood flow. So spontaneous ventilation is very beneficial. The next slide may seem like a very complicated algorithm, but essentially, if you think of it, it is to keep the same two goals of adequate oxygen delivery and adequate CO2 elimination. And the different modalities of ventilation are SIMV pressure control, which is synchronized intermittent mandatory ventilation pressure control, or SIMV volume control. There is no benefit of one mode versus the other. The suggestion is use what your institution or your group or your teams are most used to. And the different parameters are obviously FiO2, tidal volumes between 4 to 7 ml per kilo. There's the respiratory rate depending on the age between 15 to 35, and in I time of 0.3 to 1 depending on the age, and there's PEEP. So if there is adequate O2 delivery and adequate CO2 elimination, then you wean the FiO2, wean the respiratory rate, make sure the X-ray of the patient doesn't show a significant pneumothorax or a pleural effusion, and you do what we call a CPAP pressure support trial. So put them on a rate of 0, pressure support depending on the size of the endotracheal tube, a low FiO2 to get adequate saturations, and that depends on the structural heart defect and what the pathology of the patient is. And lastly, look for spontaneous ventilation volumes of about 6 ml per kilo, maintaining normal saturations, and lastly, maintaining normal worker breathing. And that's really important because that's your oxygen delivery to oxygen demand balance figure I showed at the beginning. Once these are all stable, your patient's ready to be extubated. If your PaCO2 is high, then you have to essentially increase your respiratory rate or your minute ventilation by increasing the tidal volumes. If your saturations are low for a non-single ventricle patient, then you move on to the inadequate oxygen delivery algorithm. The three main categories when there is inadequate oxygen delivery is either there's a right to left intracardiac shunt, or there's an intrapulmonary shunt, or there's an alveolar hypoventilation. And if there is a right to left intracardiac shunt, ventilation may not be the right answer. There are certain things where you increase oxygen content, like improving hemoglobin and improving cardiac output by pharmacological maneuvers. For intrapulmonary shunt, yes, changing some things in the ventilator, like FiO2 and optimizing PEEP are definitely key. ECMO comes down here. Not all centers have ECMO. Some of these patients may need ECMO, but most of these patients have significant OR courses. So it's not specifically for respiratory failure that they'll need ECMO. And then alveolar hypoventilation, as I said, you optimize the minute ventilation by respiratory rate and by tidal volume. So mechanical ventilation, in summary, decreases oxygen consumption, increases oxygen content, and increases cardiac output, thereby favorably altering the supply to demand relationship, but may not be the correct answer depending on the pathology of the patient. This talk would be remiss if I don't talk about pulmonary vascular resistance. So it depends on age. So neonates by definition have very high PVR. Anatomic deficiencies or acquired PVR abnormalities because of physiological changes, like our trisomy 21 patients have very reactive pulmonary vascular beds. So as far as management goes, maintain your lung volume close to your FRC related to the first graph, normal to high PaO2, normal to low PaCO2, and normal alkalemic pH. Inhaled nitric oxide is a very good selective pulmonary vasodilator, not only useful for cyanotic patients with pulmonary hypertension, but also in the cavopulmonary anastomosis group where cardiac output depends on passive pulmonary blood flow. And then in these patients, sedation and paralysis is very essential in pulmonary hypertensive crisis. This is an algorithm for pulmonary arterial hypertension, which is right ventricular hypertension or pulmonary vascular hypertension. Modalities to improve it are increased FiO2, positive airway pressure ventilation, balancing the overexpansion and underexpansion based on that graph you remember. And then there are pharmacological maneuvers like inhaled nitric oxide, milrinone, and if severe, these patients may need extracorporeal membrane oxygenation. Non-invasive positive pressure ventilation has emerged in the recent years as a very effective modality for either a bridge from extubation to spontaneous ventilation or a bridge to needing intubation. Modalities are continuous positive airway pressure, bilevel positive airway pressure, and high flow nasal cannula. How does it work? It decreases LV afterload, it improves gas exchange, and decreases death space. The last one is important in kids who have increased worker breathing, because that may significantly decrease metabolic demand. So what happens if you have to intubate these patients? And back to Ruby's PC4 cap bundle, very important to think of these things. So know your cardiac output, know what the ventricle is doing before you think of intubating this group of patients. Think of the sedation drugs you're going to use for intubation and what these sedation drugs can do. For example, bradycardia, hypotension. These can significantly lead to bad outcomes, so be prepared, anticipate problems. Full gastric contents, risk of aspiration, and then risks of positive pressure ventilation and the cardiopulmonary interactions. Lastly, procedural sedation is definitely a myocardial stress in these patients, especially if they have small reserve. So think of all these factors if these patients need reintubation for any reason. There are multiple papers on this, but significant systolic dysfunction of the systemic ventricle in these patients is strongly associated with cardiac arrest during intubation. So something to think about and needing help. Special considerations for respiratory management. So phrenic nerve injury is seen in these group of patients after congenital cardiac surgery. The way to diagnose it is fluoroscopic imaging during a spontaneously breathing patient. What I mean by that is you suspect it if on a chest x-ray you see persistent hemidiaphragm elevation, and then you either do an ultrasound or fluoroscopic imaging in the mechanically ventilated patient by disconnecting the endotracheal tube from the ventilator. And if you see paradoxical movement, that's indicative of hemidiaphragm paresis or paralysis. Recurrent laryngeal nerve or vocal cord paralysis is seen in patients with ductus arteriosus surgeries and or aortic arch abnormalities who've had surgeries, seen as vocal cord hoarseness of the voice, no cry, etc. That is different than upper airway obstruction caused by the trauma of intubation. Pleural effusions, fortunately, most pleural effusions post-op are responsive to diuretics. Chylothoraces can definitely be problematic, seen more commonly in Glens and Fontanes because of high pressures. There are still many times that you can still successfully extubate these patients and they may stay with chest tubes chronically. Last but not the least, trauma of intubation, neonates, small infants, complications related are subglottic edema and stenosis. That's all. Thank you very much and happy to take any questions.
Thank you, Pooja, for a great, thorough talk. That was really well presented. We're going to try to save all of our questions towards the end. And that's how it worked really, really well last time. And just to remind everybody who's on and listening to please feel free to post your questions in the chat. And Dr. Zahn and myself will be able to see all of those and then be able to bring them up towards the end and discuss with everybody. So thank you, Pooja, again. We're going to move on to the next talk. It gives me great pleasure to be able to introduce several of the next speakers. But Dr. Yates, Andy Yates, is a colleague of mine here and a close friend and actually near neighbor of mine. And he's going to speak on the basics of inotrope and fluid management following congenital heart disease surgery. And his expertise is in our cardiac ICU and taking care of some of the most complex patients with congenital heart disease. So thank you, Andy, it's all yours.
Great, thanks for the introduction there, Darren. Maybe we'll go here. All right, hopefully everybody can see that.
We can hear you and see that very well.
Perfect. All right, I appreciate the opportunity to chat with everybody here today. I do have a few disclaimers before I start. I think it's already been said here in several different formats already, but I just want to emphasize that ICU medicine really is a team sport. We as physicians in our ICU are so dependent upon our bedside nurses, our respiratory therapists, and everybody to make sure that they are the first line of response, that they recognize patients that aren't progressing as they should and are on the verge of deterioration, so that they can alert us and get us to the appropriate places so that we can all provide the appropriate care at the right times. Also, I just want to emphasize a couple of things as we talk about different inotropes and ICU care. I think in medicine, there's often no, quote, right way to do things. Often there's many right ways to skin the cat, as people would say. However, there are sometimes wrong ways to do things, and it's important to realize what the wrong ways are. Also, different hospitals and countries have access to different medications. And so I try to select medicines which I thought would be relatively universal, although that may not be true depending on which hospital or country that you are from. And then when in doubt, one of my big tenets that I was always taught in my training is when in doubt, examine the patient, because often that'll help clarify what's going on and which course of therapy should be explored. So as we know, when we take care of children after heart surgery, they all essentially undergo cardiopulmonary bypass, and that in itself is a necessary evil for the surgeons to do their work. The results of that for us in the ICU are that we end up with myocardium that sometimes has ischemia reperfusion injury from cardioplegia. In addition, there's localized inflammatory responses that lead to myocardial edema, leading to poor systolic and diastolic function. Additionally, there's effects on the vasculature, particularly the inflammatory response of the components of the circuitry of the bypass machine that lead to capillary leak. That results in pulmonary edema and sometimes ventilatory issues, as we just heard about, but also systemically, we end up with third spacing issues as well. And the result of that inflammatory response is also an endothelial injury, which results in elevation of the systemic and pulmonary vascular resistances, which further complicates the post-operative hemodynamics. In general, when we lump all of those things together after cardiopulmonary bypass, we refer to that as low cardiac output syndrome, or LCOS, as I'll refer to it throughout the rest of the talk. And that's typically related to a decrease in cardiac output at approximately 6 to 18 hours after bypass. So when we think about our goals of inotropic support of patients after bypass and as they're recovering in our ICU, really we want to try to maintain cardiac output. And how do we do that? We really work to maximize contractility and minimize additional afterload on the heart. If we can maintain our cardiac output, then we will assure our end organ perfusion and good results of our surgical care and our ICU level care. At the same time, we're trying to minimize side effects. And so with inotropic support, typically that's utilizing the lowest necessary dose for the shortest duration possible, as all medications have side effects, as we're aware. So I'm just a simple ICU doctor, so I try to keep things as simple as possible when I think about catecholamines and different inotropes. So in general, I think of alpha drugs as mainly being vasoconstrictors, beta 1s as being mainly chronotropes and inotropes, and beta 2 drugs being mainly vasodilators and inotropes. There's a nice motor neuron that's there as a reminder of how all of those complex interactions happen, and we're not going to talk about any of those. I think the big points are that there are no pure drugs when we talk about catecholamines and different inotropes, and that you get some mix of effect from all of the drugs that's there. I stole shamelessly this photo of just a list of drugs with the relative strengths of alpha versus beta effects, which I think is a great example that drives that point home. We have some drugs like isoproterenol, which are almost pure beta drugs, and a few like phenylephrine that are almost pure alpha. But in general, the bulk of the drugs that we use for inotropic support end up being somewhere in the middle of that spectrum with both effects. So when we think about low cardiac output syndrome after bypass, this is really a form of shock, and that really goes back to the inability to supply oxygen to meet the metabolic demands of the body. And so then how do we maximize our cardiac output? We know that that's related to heart rate times stroke volume, and that product is there. We're not going to discuss arrhythmias and management of heart rate and such things just for simple sake of time. But we do need to talk about stroke volume, and that's mainly influenced by preload, contractility, and afterload. Additionally, there's other hemodynamic things which can affect cardiac output, such as tamponade, and I'm not going to be discussing that either. So when we think about preload, generally that's the volume that the ventricle has something to actually do with or to do work to eject. And traditionally, we measure that in the ICU setting using a central venous pressure or a right atrial pressure. However, there's an important confounder in there is that we're measuring a pressure and making an assumption then about the volume that the heart actually has something to do with. And those, depending on the state of the myocardium and the filling pressures and diastolic function, can be very unrelated to each other. And so post-operatively, there's this balance between maintaining adequate preload and avoiding fluid overload and third spacing. And so generally, my approach has been to use less than maintenance IV fluids as a continuous infusion, and then additional bolus doses as needed to maintain preload. And all the time, we're monitoring for physiologic responses as well. So if we provide extra IV fluids in bolus format, what I'm looking to see is, does my blood pressure increase more than my CVP or right atrial line? If so, then that means I have some preload reserve and that I'm actually providing cardiac output with additional volume enhancement. However, if my central venous pressure would go up with a volume bolus, and it goes up the same or more than the blood pressure response, that means I've actually overfilled the myocardium, and that I'm actually negatively impacting the hemodynamics and potentially contributing to third spacing and volume overload for my patient. And so then we should stop giving fluid and think about start giving an inotrope to improve our contractility. When we talk about contractility, that's really the ability of the myocardium to generate force. And so we think of that generally as pressure volume loops and increasing responses. Contractility is impacted by many things, including parasympathetic and sympathetic activation, afterload and heart rate of the patient, in addition to the circulating catecholamines that we can provide externally. Anytime we talk about contractility, it's important to mention calcium. Calcium is an important ion, and it's important for all depolarizing cells, not just muscles, but also neurons, etc. And so it's responsible for contraction and relaxation of all muscular substrates, and not just myocardium, but also smooth and striated muscle. And particularly, infants are much more dependent on ionized calcium than older children, although it is still applicable in that population as well. And so generally, we're going to try to maintain ionized calciums greater than about 1.2 millimoles per liter. Some centers use 1 millimole per liter, so there is some institutional specificity on that. And in general, it's going to be via one of two mechanisms if we need to replace calcium. Now, once our calcium stores are replete, we have adequate preload on board, then we're going to increase our inotropy with addition of low-dose epinephrine predominantly. And at low doses of epinephrine, we get more beta effect, and at higher doses of epinephrine, we'll end up with more alpha effect and peripheral vasoconstriction. And so if we're really providing inotropic support, we want to have lower doses of epinephrine traditionally. Epinephrine acts at the beta-2 receptors traditionally in the cardiac myocytes, and then actually leads to production of cyclic AMP. Cyclic AMP then impacts calcium handling in the cells, and so then results in more contraction in myocytes. The biggest side effects of epinephrine are really related to increased myocardial oxygen consumption. Anytime we're making cells and driving cells to do something energetically, there's a cost to that, and so that happens by increasing oxygen consumption of the myocardium. Certainly arrhythmias and tachycardia are other side effects, and at higher doses, decreased renal and splanchnic blood flow. Dopamine has traditionally been used for inotropic support following cardiac surgery in pediatric patients. It is the native precursor to norepinephrine. And there's this traditional dose-dependent effect where at low doses you get more renal effects, and at moderate doses you get more beta-1 effects, and at higher doses more alpha effect from dopamine. My caveat is that I rarely utilize dopamine as a first-line agent, and the reasons for that are really related to immunosuppression, endocrine dysfunction, arrhythmias and tachycardia in patients, and there's some studies in adults where it actually had detriments on outcomes. So for me, dopamine is down my list of agents that we would traditionally use, and it has been at our institution. So I refer to dopamine as the devil, and even though he is a little cute devil. All right, so another way that we can affect our cardiac output is by adjusting afterload. And that's really the resistance against which the ventricle has to contract. And indirectly, that's a reflection of myocardial work. And we think about that as really measured by systemic vascular resistance, which is a product of your mean arterial pressure divided by your cardiac output. In the ICU, realize we traditionally use arterial blood pressure or mean arterial pressures as a marker for what our SVR is. They are related to each other, but there is another factor that can play into that. So we need to be a little bit careful with that assumption as well. Milrinone is probably the drug that's most utilized after cardiac surgery in pediatric patients to affect afterload. It is a phosphodiesterase inhibitor and results therefore in increased intracellular calcium stores in the heart that results in an increased inotropy and lusotropy or relaxation. But out in the vasculature, it results in smooth muscle relaxation and decreasing afterload. Just to diverge back to our diagram a moment, we talked about epinephrine, how it increases cyclic AMP by blocking phosphodiesterases. Then we prevent the breakdown. Again, so one of my favorite combinations of medicines for patients with very poor cardiac function is low-dose epinephrine with some milrinone as well, because that then can drive production of cyclic AMP while preventing the breakdown, resulting in maximal levels of cyclic AMP intracellularly, which to me makes a ton of pharmacologic sense. So additionally, when we think about milrinone, there's a traditional loading bolus, which is associated with it. I rarely load because the potential biggest issue we have is hypotension with loading doses of milrinone. And then particularly in children and infants after cardiac surgery, the half-life can be very long and even longer with renal impairment in patients. And so you have to be very careful, I think, with rapid administration. And so my traditional approach has just been to turn on an agent at a dose and then wait for it to accumulate and have effects. Other potential effects other than hypotension are thrombocytopenia and arrhythmias with milrinone utilization. This is one of the few drugs in pediatric patients that has been studied in a placebo-controlled study. This is now an older study back from 2003, which was the Primus core study. They looked at patients that received milrinone versus placebo in post-operative repair of congenital heart disease. And they demonstrated the usage of milrinone at a higher dose resulted in a relative risk reduction of low cardiac output syndrome or death in those patients in the first 36 hours. And then in effect, it actually up to 30 days, although most of the badness that would occur was early on, as you would expect. So this is one of the classic papers that discusses inotropy in patients following cardiac surgery. All right, so what do I actually do practically with all of this information? So number one, I go back to one of my tenets, which is examine the patient. I make sure we have adequate preload on board and we fill the tank up, and while I look at our CVP. Then I'm looking at our blood pressure for a measure of how much afterload is on board, and our contractility by looking at our pulse pressure and making sure we have adequate coronary perfusion as well. I think about normals for age, whether it's from Harriet Lane or other types of resources for what you would expect that are an age-based approach. And then in my exam, I want to look at what the capillary refill is like, how warm peripherally the patient is, or as a marker of their perfusion. And then additionally, what their mental status is like. in particularly patients that are agitated, and we initially would assume that would be pain related to post-operative state. Sometimes agitation can also be related to low cardiac output and poor cerebral perfusion, and so it's important to try to differentiate those. Finally, we're looking at urine output and labs, and that comes farther down my list other than my exam of my patient. So as practical examples here, so our first patient is a 6-month-old after a VSD repair, who has a heart rate of 195. It's sinus rhythm, even though it's fast. The blood pressure is low at 50/20. Right atrial pressure is only 2, and patient is well saturated. And so there's several options that I listed as initial courses of action. You could either start epinephrine at 0.3, start some milrinone at 0.5, or bolus with 10 per kilo of IV fluids, or obtain an echocardiogram. This is obviously wrong because I talked about this not at all in the entire talk. So in this patient, I would have initially bolus with some IV fluids, given my hypotension, tachycardia, and low right atrial pressures for the physiology and monitored response. So after a total of 30 mLs per kilo of volume, the patient's heart rate has come down a little bit to 150. The blood pressure is slightly better at 55/35, but now my CVP and right atrial pressure is all the way up to 12. And importantly, with that last 10 per kilo of volume, there was no blood pressure response, and the CVP increased by 4 points. So you have options now of continuing to give smaller boluses of IV fluids, start some epinephrine at 0.05, start some milrinone at 0.5, or obtain an echocardiogram. So this is a situation where I would start epinephrine at 0.05 mics per kilo per minute. I have evidence of systemic impairment where I have hypotension that has continued. I need some inotropy because my CVPs have started to increase, and so giving additional volume would not have happened or been helpful. And in this situation, I would not initially start milrinone as I'm somewhat hypotensive already, and so I would opt for epinephrine in that scenario. And then as a final example here, a 5-month-old after repair of tetralogy of Fallot. Oops, excuse me. Well, now everything's going off. There we go. Came back from the OR about 8 hours prior. His heart rate is 180, has a normal sinus rhythm as well. Breathing in the 40s, blood pressures are 80/55 with a CVP or right atrial pressure that's up to 16. The child on exam has no urine output, cold extremities, and a gallop. And so as options, you could start some epinephrine at 0.05, start some milrinone at 0.25, obtain an echo, or give 10 per kilo bolus of IV fluids for low urine output. In this scenario, this would be a milrinone candidate for me, given the robust blood pressure CVP, and so dropping the afterload and helping inotropic support with milrinone would be my preferred approach in this patient. So thank you for your time and attention. Hopefully this has been helpful. Here's my contact information for other questions. If you think of things that we don't get to later in our discussion options, certainly please write your questions that you would have in the chat box, and we can come back to those as Dr. Berman mentioned. Thank you.
Thanks, Andy, for a great talk and awesome overview of that. I know I learned a bunch just listening to you talk there. There's one question posted already, and like you said, we're going to save them for the end. So we're going to move on and get through the talks, and then hopefully have a dynamic discussion at the end. So it's my pleasure to invite Dr. Lloyd to speak next. His specialty is as a pediatric intensive care doc, and is additionally subspecialized in care in the cardiac ICU. He is an amazing clinician and a wonderful bedside teacher, and is going to talk to us on post-operative management of left to right shunting lesions such as ASDs, VSDs, and canals. And with that, we'll hand it over to Eric to share his screen with us.
All righty, is that working for everybody?
Yep. Just
Yeah,
got
we can go to presentation mode.
Yep.
We can see your screen and we can hear you.
Okay, great. Thank you for the invitation to come here and speak today, and thank you for the warm introduction, Darren. I only had to pay him $20 to say all of those nice things about me. I'm here today to talk about left to right shunts. I have two disclaimers. The first disclaimer is that Andy lied. He is not a simple ICU physician. I am the simple ICU physician in the group. And the other thing is, like all good ICU docs, a lot of this stuff we sort of make up, but say with authority. Neither one of those disclaimers I'm going to put down in writing because I don't want any proof of them out there. So quickly, just some objectives today. So wanted to just discuss the short-term complications and post-op management for ASDs, VSDs, and AV canals or AVSDs. So first, just so we're all on the same page here, the primum defect is fairly rare to be in and of by itself. Often it is accompanied with a mitral defect, sort of the partial AVSD that we'll talk about in a little bit. Most often these are small and don't lead to many problems if they are by themselves. The ostium secundum defect tend to be a little bit larger. They have less ability to regress if they're larger than somewhere around 8 to 10 millimeters, and if they're still present later on in life. The sinus venosus defects most commonly are in the SVC location, and they're often associated with partial anomalous pulmonary venous return. The coronary sinus defect, it's not truly atrial septal defect, but it gives you physiology similar to an atrial septal defect, and often is associated with a left-sided SVC. So just real quick, I know we touched the primum defects. Usually they're smaller, don't cause as much overcirculation when they're present in isolation. About half the time they occur with mitral valve defects, and we could talk about that in a little bit. Secundum defects, they, like I said, less likely to spontaneously close if they're larger, if they persist later on after the toddler age. If they do persist, then looking for signs of increasing size in right-sided structures or increasing pulmonary vascular resistance due to the overcirculation would be reasons for having them closed. They're often closed in the cath lab since morbidity and mortality is very similar to surgical closure, except there's less cost, less hospital stay when done in the cath lab. Usually if it's going to be a surgical repair, it's fixed either primarily with suture and closed with a suture repair or a patch repair. Both of those have relatively short bypass times. The longer that they go on, then you can see problems with complications of arrhythmia and pulmonary hypertension if they're not addressed in childhood. So skipping forward to a little bit more of the clinical pearls and a little bit more complicated ASD repairs. So the sinus venosus defect, like we said, it's often associated with partial anomalous pulmonary venous return. You can see the diagram here. What the surgeon will typically do is open up the right atrium and set forth a baffle inside the right atrium to try to take the pulmonary vein return that's going into the right atrium and baffle it as he closes the atrial septal defect, so that the venous return from the lungs is now going to the left atrium. The problem that can occur with these is, as you can see where they're sewing the patch in, where the retractors are, it's very close to the sinus node. And so that you can see roughly 10% of the time atrial arrhythmias that can occur with this type of repair. So just say here, there's a 5-year-old who was found to have a sinus venosus repair. There was partial anomalous venous return, so had a baffle placed, comes back to the ICU, and when you look at the tele, you kind of see this. So you see periods of bradycardia, periods of tachycardia. Some of it looks like sinus node that then gets transmitted. Some of it looks like AV node. And so what has happened here is you're having issues with your SA node and sick sinus syndrome. So often, if this is tolerable, then you're okay. But as you can see with this patient here, there's pretty long periods of bradycardia that would make people quite nervous. Also periods where the ventricular rate is quite high could also make people uncomfortable. So while this is usually a short-term process that often resolves, sometimes you need the help of temporary pacing if there's prolonged periods of bradycardia. Hopefully there are wires in the child. And sometimes that with the faster rates, you might need issues with slowing down your rates and use of such medications as beta blockers. Some other problems that you might see in patients with sinus venosus repair, you can see here on the left, a 10-year-old boy who had his sinus venosus defect fixed. The surgeon came back and said that the pulmonary veins came in kind of high in the SVC, and so the baffle was kind of long. And you notice progressively throughout the day that his face and neck seem a little bit more swollen. And sometimes this occurs in patients who end up with SVC syndrome because the patch, the baffle that's there, decreases the size of the SVC, and you just have venous congestion of the face and neck and sometimes upper extremities. Often just keeping these patients in an upright position, and with a little bit of time, things can get better. You can see here on the right an x-ray for a teenager who went to the OR, had a similar repair, except you notice on the x-ray how the right lung looks more opacified, hazier, more congested than the left. Sometimes the baffle that they put in there is just a little bit tight, maybe a little bit malposed, so that the venous drainage from that right lung is impaired. Unfortunately, that's a little bit more complex and isn't something that gravity can just help. Hopefully it's something where the venous pressures aren't too high in that lung, and over time things can get better. So overall, with atrial septal defects, the mortality of the repair is quite low, around 1% or less. What you really want to watch for is patients showing signs of elevated right-sided pressures going in to the OR. We'll talk a lot more about pulmonary hypertension and stuff with our other cases, since they're more common with other cases than your typical ASDs, but watch for it. If there are signs of elevated right-sided pressures, then you might want to have a discussion preoperatively about decreasing the size of the atrial septal defect with a fenestrated patch, and then allowing for medicines to help treat the elevated right-sided pressures, hoping that they will fall with time. Keep in mind watching out for atrial arrhythmias, pacing for slow rates, beta blockers for tachyarrhythmias. Moving on to VSDs. So just a few words so we're all on the same page. Typically we talk about 4 types of VSDs. Usually we want to focus on this talk with pitfalls of post-operative care, but just so we're all on the same page, muscular VSDs are often a little bit tricky to repair surgically and often taken care of in the cath lab, just because they often are multiple and difficult for the surgeons to find. They often can spontaneously close, so watching them over the first few months to years of life is important to see if they do close. Outlet VSDs or subpulmonic, subaortic VSDs are often smaller. They usually do not close on their own and require surgical intervention. Because of the smaller nature of them, it's not typically a problem with over-circulation for the patients, but a problem with impinging on aortic valve. The effects of the flow through it causing problems with the aortic valve cusp and just aortic regurgitation. Perimembranous are by far the most common. They often can extend into the inlet and outlet portions. They also can have aneurysmal tissue of the septum of the valves that help to close them a little bit over time. And then inlet or canal type of VSDs are often quite large and often over-circulate quite a bit. you can kind of see when we talk about large, moderate, and the differences amongst them for classification states. So real quick, so here's a 5-month-old with a very large perimembranous VSD with outlet, inlet extension, who has failure to thrive, is on multiple heart failure meds, goes to the operating room and has a patch repair of the VSD, got extubated in the operating room, as we typically try to extubate patients early on in the operating room. Was started on milrinone because there was some concern with how large the VSD was and helping to try to prevent any post-operative low cardiac output states. So the patient has a good night, but on post-op day 1, you stop the milrinone, started some diuretics, and you're hoping to get the kid moved along and out of the ICU. But before he gets out of the ICU, several hours later, you get called over to the bedside because they notice that the patient is more tachycardic, he's cooler peripherally, he's more tachypnic than he was, his urine output's okay. And so they're concerned with trying to get the patient moved along and getting out of the ICU. So the one thing to keep in mind is with such large VSDs in patients who are going into the OR with heart failure especially, that depressed LV function after the repair happens. Usually it happens somewhere around 1/3 of the patients. Most of the time the LV dysfunction is not severe and something that is not that worrisome. And it usually will get better at time within 6 to 9 months after the operation. LV function can improve to normal. The issue being that in a patient like this who very quickly showed that being off of some IV medications that helps with afterload and contractility, that there was some deterioration that happened. So patients like this, even though it gets better with time, they might just need a little bit more time. And so this is a patient who probably would go back on IV milrinone, keep the diuretics IV, and maybe if work of breathing was severe enough that you would use some positive pressure ventilation, hopefully non-invasive, to try to help with afterload reduction of the LV and help with metabolic demands of the patient. So you just might need to take it a little bit slower in patients like this who have large VSDs. How about a 5-month-old with a large inlet VSD? Had a patch repair in the OR, everything went as planned. He comes out to the ICU, is extubated on milrinone. You take a look at the monitor, and much to your dismay, the heart rate is quite low. You can see that there are many P waves, and it doesn't really seem that they conduct very well. So it looks like you have complete heart block. So while it's rare to have heart block because of VSD repairs, somewhere around 1 to 5% of cases, it is more common with inlet or perimembranous with inlet extension VSDs. And you could see there, you could see that it has to do with the conduction system. Conduction system being very close to the defect. So really the answer is, what do your hemodynamics look like? Like Dr. Yates said, examine the patient, examine the patient, examine the patient. So does this child have a escape heart rate, even though it's ventricular rate? Is it a rate of 80? Is that enough to have good blood pressure, good perfusion, good urine output with normal gases, normal lactate? If not, then that tells you that your heart rate is too slow, or you need AV synchrony to get that atrial kick to help with stroke volume. So hopefully the kid came out with pacers, especially if it was as slow as what the monitor had showed in the previous screen, so that you can go ahead and pace the child. And doing it in a mode where you can get AV synchrony would be best for cardiac output. If there are no wires and your heart rate is low, using isoproterenol might help to raise your heart rate some, but ultimately you might have to talk to a surgeon about putting temporary wires in. Usually within 8 to 14 days, if you don't have resolution of heart block, then it's probably going to be permanent, in which case you need to talk to the surgeon about having a permanent pacemaker placed. Usually the surgeons have a pretty good idea. If something happened in the OR, they sometimes don't lead on to as much as they known, but I've seen before where children have come out of the OR with actual permanent pacing wires in place, just hooked up to a temporary pacemaker. That sort of gives me the idea that that's probably not going to come back. So just real quick in summary, VSD, so usually closure surgically is well tolerated. If there is a delay, that increases the risk for pulmonary hypertension. Outlet defects usually smaller, repair them when your aortic regurgitation worsens. Muscular, usually best for the cath lab. And then we had a little bit more discussion about inlet and perimembranous and post-operative complications that you can see. So an AVSD, or complete endocardial Cushing defect, you can see the nomenclature from complete, intermediate, transitional, partial. A lot of this gets bantered around, but essentially we'll be chatting a little bit more about partial AVSDs, since we talked about it earlier, and complete AVSDs. So let's take a look at those cases. But essentially what we're looking at is how well the AV valves had formed embryologically, and what is sort of the septal defects that are left. So let's say here there's a 3-year-old with a partial AVSD, so has a primum ASD and a mitral cleft, who goes to repair in the OR. The ASD is patched, the mitral cleft is repaired via sutures. Everything goes well, comes back, he's extubated in the ICU, looking okay. The next morning, you notice that he's more tachycardic, more tachypnic, and you get a chest x-ray, and your chest x-ray kind of looks like this. So it looks more like you have signs of pulmonary edema. So you're left with trying to piece things together, that there are signs of left atrial hypertension. So the question is that when the surgeon repairs these valves, they try to do it in a manner so that there is minimal mitral stenosis and minimal mitral regurg. Sometimes that gets a little bit tricky for them. So you hope that in the OR, the TEE had helped them to show that their repair was adequate or not. And if not, they could address it at that time. The reason why it's important to sort of tease these out is that with mitral regurgitation, you can afterload reduce these patients, diurese them, and hope that they can get a little bit better. With mitral stenosis, you can run into problems since they have a fixed stroke volume, with afterload reduction just worsening things with systemic hypotension and not actually helping the patient. This case in particular, what ended up happening was the repair of the mitral cleft actually dehisced, and so the patient had horrible mitral regurgitation after a somewhat good repair based on TEE. And that's why the child was doing okay at first, and then sort of had a quick change in clinical status within a short period of time. How about another case, a 6-month-old with Down syndrome and a complete AVSD who underwent a 2-patch repair in the OR. Things went well in the operating room, came to the ICU, still remained intubated just because of some bleeding post-operatively and wanting to make sure that everything went well. During the middle of the night, you are going around, get called to the bedside by the nurse because the patient seems a little bit cooler, a little bit more tachycardic. You notice that the right atrial pressures are now up a little bit into the mid-20s, where they had previously been in the lower teens when the patient arrived from the OR, completely still sedated under anesthesia. The liver feels down a little bit. So all of these signs look like low cardiac output, but the question is Is this low cardiac output from LV dysfunction after coronary bypass, or are you running into problems with pulmonary hypertension because you know that having a complete AVSD and Down syndrome puts them at a little bit higher risk? So a couple things. Usually when you have LV dysfunction, the right-sided pressures can be elevated, but typically when they start getting up into the 20s and 30s, then that's typically more a sign of pulmonary hypertensive problems. I know that this is not a test-taking question, because on the test you'd have to say, oh, I need to know what my left-sided pressures are before I say where the problem is with the increase in pressure. But unfortunately, that's usually not how it is in real life. A couple things to remember is that afterload reduction with milrinone can help with LV dysfunction, assuming that your blood pressures are okay. It also can help with lowering pulmonary vascular resistance, so help with pulmonary hypertension and RV dysfunction. Things like reversing acidosis can help with pulmonary hypertension and also help with LV dysfunction if you're acidotic. Sedation can help to decrease metabolic demands. Giving oxygen is a pulmonary vasodilator and can help, even if it doesn't help much with LV dysfunction, it's still something that's very easy to do. So a lot of things that you can do, even though there's still questions as to where the problem is, can help with both LV dysfunction and pulmonary hypertension. The issue might arise since you believe that this to be pulmonary hypertension, given that the RA pressures are quite high. Things like inhaled nitric oxide and inhaled prostacyclins have been shown clinically to be beneficial in acute pulmonary hypertensive crisis. So as this patient becomes more awake and alert and RA pressures then are jumping up into the 40s and 50s and your tachycardia is now becoming bradycardia and your normal blood pressures are now dropping, these are measures that can be beneficial in those acute situations. However, they're fairly costly and they might not be readily available. Things like sildenafil have been shown to help bridge, once these patients are having their out of their acute pH crises, bridging them off of these more expensive medicines into a cheaper, more available thing can be helpful. The question is, if you don't have nitric and inhaled prostacyclins, maybe even starting sildenafil sooner rather than later for these patients might be of benefit, but that's not something that's actually been proven quite yet. Just one other thing, make sure that with the AVSDs, the complete defects, that you can see where your AV node is in comparison to the lesion, and so they still are at risk for heart block and jet, which I believe your next lecture will talk a little bit about jet, so we won't talk about that just yet. So in summary, the AVSDs are a little bit more complex than simple ASDs or VSDs because of the higher risk of pulmonary hypertension and arrhythmias, and also the complexity of the valve repairs that must be done. Just keep in mind that about 20% of these patients will need a reoperation some point in their life, usually before adulthood, usually to help with left-sided AV valve issues. And if there are going to be candidates for prosthetic mitral valves, that carries a risk for post-op heart block. So just a few pearls. Remember that left to right shunts are usually well tolerated, the repairs of them. Pulmonary hypertension is the major risk leading to morbidity and mortality. So looking how large the shunt and how long it's been present are the major driving forces for pulmonary hypertension, and things that you want to think about preoperatively for these patients to plan post-operative care. And remember about the rhythm and valve issues that we talked about during these cases. And with that, let me see if I can send this back. Stop sharing.
Thanks, Eric, for that. Great talk and really nice case-based examples to learn from and take away from. We're going to move on to our last talk and then have some time at the end for some question and answers. So we get the opportunity now to invite Dr. Gauntt, Jenn Gauntt, to give us a talk on the post-operative management of tetralogy of Fallot. She joined our heart center just a couple of years ago and is a cardiac intensivist who's been wonderful, wonderful to work with. So Jenn, take it away.
Thank you. And I am the last talk. Hopefully everybody's holding on strong here. It is a bit challenging for me to follow Andy and Eric, who have been my mentors as I joined the group about 2 years ago, and they've been here for a lot longer than that. Dinosaurs in the unit, I think. We're going to talk about the post-op management of tetralogy of Fallot. The objectives today are really to identify the components or the goals of surgical repair of tetralogy, and to describe the challenges that can occur post-operatively after surgical repair, and the treatment strategies to mitigate those challenges. So just by way of refresher for everybody, tetralogy of Fallot is a constellation of 4 abnormalities. The first is narrowing of the pulmonary valve, so pretty stenotic area of the valve that can be valvar and below the valve as well. The second component is RV hypertrophy or thickening of the right ventricular wall, which causes additional crowding under the pulmonary valve. There is displacement of the aorta over this anterior malalignment subaortic VSD, and then this VSD is the fourth component, the opening between the right and left ventricles. There are a number of associated anatomical abnormalities for tetralogy of Fallot. About 25% of the patients have a right-sided aortic arch, which can present difficulties in the sort of palliative stage in the setting of maybe considering a BTT shunt for a patient prior to complete repair. A right-sided aortic arch might complicate that. About 10% of patients have anomalous coronaries. A couple of the important ones are the LAD from the right coronary artery, and that can cross over the RVOT. And that's important to recognize preoperatively because there's going to be a lot of work done in that RVOT area. And of course, injury to the coronary would be catastrophic. There also can be dual LAD supply. Some patients will have more than one VSD, so a VSD in addition to that large subaortic VSD, including in the muscular region, and these may not be readily apparent even preoperatively and might not present themselves until the postoperative time period. And then there are a handful of patients who also could have multiple aortopulmonary collaterals that can complicate the repair somewhat. So there are several goals to the surgical repair of tetralogy. The main goal, first main goal, is to close the VSD, which is done with patch material. And next is really to widen the right ventricular outflow tract. So this is done by doing work under the valve, above the valve, and in a lot of cases requires patching across the valve or transannular patch repair. Those patients who are getting transannular patch repairs are then at risk for or will develop free pulmonary insufficiency that can develop to RV dilation over time, and something that will be followed long term. After widening the outflow tract, the last component is to relieve any pulmonary artery stenosis that might be present kind of post the MPA, and especially in the area of the duct, as the duct has involuted and caused any constriction of the branch pulmonary arteries. There are multiple things that can complicate the postoperative course. I'm going to just touch on a couple of them for you today. I think the most common ones. Those are conduction disturbances, residual defects, and right ventricular dysfunction. And any one of these challenges that can occur postoperatively could lead to low cardiac output syndrome. And Andy talked a bit about the management of low cardiac output syndrome with milrinone and potentially epinephrine. But if any of these postoperative concerns happen, then we could have to manage a patient with low cardiac output. So let's start with a case. We have a 4-month-old who's returned to the ICU after complete repair of tetralogy. His heart rate is 195 beats per minute, and his blood pressure is low at 60/35. So we're thinking about what's going on here. We're going to obtain an EKG. Hopefully the patient also has some pacing wires, and we can obtain an atrial electrocardiogram. Most likely what's happening here is junctional ectopic tachycardia. There are some other arrhythmias that can happen post tetralogy repair, but jet is the most common, happening in about 15% of patients. This is a narrow complex tachycardia. The rates can be between 170 up to 260. Usually this is associated, this has AV dissociation, so the atrium and the ventricle are not contracting at the same time, and that dissociation or dysynchrony is what causes the hypotension. In cases where there is dyssynchrony, the atrial rate is usually slower than the ventricular rate, and the ventricular rate is what we are monitoring when we get a patient's pulse. So this is happening post-operatively, likely because of manipulation of the tissue that's near the AV node during surgery. So not necessarily direct injury, but to the node itself, but to the area around the node. And the EKG in this case is going to show absence of P waves and a narrow QRS. Now, a lot of these patients postoperatively will have a right bundle branch block because many of them have had a small ventriculotomy, which can lead to a right bundle branch block. So in those cases, the QRS is not going to be narrow. So just something to keep in mind. So in JET, the sinoatrial node is actually working normally. So it's sending its signal 100 times a minute, for example. But the ventricular rate is actually coming from an ectopic focus that is near or in the AV node. So this is basically acting like a short circuit. The electricity is bypassing the AV node, and that ventricular rate is coming from this ectopic focus. And this is likely related to surgical intervention near that area and edema. So we expect this to go away over the period of a few days. This conduction abnormality, if it's severe enough and isn't appropriately treated, can lead to cardiac output that is profoundly diminished. So this will require intervention pretty immediately. The treatment of JET includes causing some hypothermia, or at least not letting patients have fever, so maybe cool them to 34 or 35 degrees. We want to reduce their catecholamines, so these patients are going to get some sedation, make sure they're nice and calm. If you have pacing wires, which many of our post-op patients do come out with, then you can do overdrive pacing to restore AV synchrony. That would be AAI pacing. And then if needed, you can also do some medications, including antiarrhythmics like amiodarone or procainamide, or a medication to slow the heart rate like esmolol. A lot of centers will use Precedex or dexmedetomidine in this setting because it will serve to slow the heart rate down and provide some sedation. And then if the patient has evidence of low cardiac output, then you'll need to be treating that as well. Case number 2 is a 4-month-old who's come back to the ICU after complete repair. The postoperative TEE showed a new muscular VSD, so the patient hadn't been noted to have a VSD before. His blood gas shows a metabolic acidosis, and his LA pressure is 20 millimeters of mercury. So what's going on with this patient? So as I mentioned, some patients can have residual or previously undiagnosed VSDs. So this would have been a shunt that was pretty much unimportant, a left to right shunt preoperatively, but postoperatively, these patients have poorly compliant ventricles. They're going to have free PI from their transannular patch, and the LV, which had not previously been volume loaded, is now going to be volume loaded. And so these may not be well tolerated. Clinically, the patient's going to have an elevated LA pressure. Postoperatively, the RA pressure usually exceeds the LA pressure in a post-op TET, but in the case of a significant residual VSD, the reverse is true. So the LA pressure will be elevated, the patient will have a metabolic acidosis and some hemodynamic instability, and you'll be proceeding down the pathway of preventing low cardiac output in this situation. So this, in this case, findings would warrant investigation with echocardiogram or cardiac cath. I will say that in most cases, a residual VSD is pretty well tolerated, so needing to have surgical reintervention after for residual VSD is rare. And over time, the RV compliance is gonna improve, and so the patients don't often need to have reintervention on this. Another residual lesion that may occur is residual RV outflow tract obstruction. So a lot of times in the operating room, the RV pressure is being measured kind of simultaneously with the PA pressure. And this is while a patient is under anesthesia. So the RV pressure may seem satisfactory or normal in the OR or only mildly elevated. But then once a patient is awoken from anesthesia and extubated, that RV pressure may go up secondary to residual RV outflow tract obstruction. And if a patient is progressing along the lines of suboptimal postoperative recovery, they're having a difficult time recovering, they're having suprasystemic or systemic RV pressures, then they may need to go back to the operating room for residual RVOT obstruction repair. Usually though, RV outflow tract obstruction is well tolerated early on, and it's usually only becomes a problem later on, and then may need reintervention at some point years down the line. Patients with RV outflow tract obstruction, though, are at increased risk of development of ventricular dysrhythmias. Question number 3 is a 4-month-old who's returned to the ICU after complete repair. So same setup. He is poorly perfused and his saturations are in the 80s, and he's got a metabolic acidosis. So what's going on with this patient? So our biggest concern for this patient is RV dysfunction. The right ventricle in a tetralogy patient is small, it's poorly compliant, and it's got restrictive RV physiology and diastolic dysfunction. And then add to that the cumulative effects of bypass, the right ventricular incision, the free PI, and maybe if there's a residual VSD or RV outflow tract obstruction, and this is a setup for low cardiac output syndrome. So these patients clinically are going to see signs of low cardiac output, including hypotension, tachycardia, poor urine output, poor perfusion. These patients will have an elevated RA pressure, secondary to the poor RV compliance. Will have signs of right-sided overload with hepatomegaly, edema, and pleural effusions on X-ray. So the treatment for RV dysfunction, the first treatment is early extubation. So positive pressure ventilation will decrease preload, and preload is very important in these patients. So early extubation would be a goal of treatment for RV dysfunction or prevention of RV dysfunction. Andy talked a bit about milrinone and its use for systemic vasodilation, and it's also a great inotrope. So the addition of milrinone will help lower PVR and SVR. Inotropic support might be needed in the setting of this low output. So we would use typically a combination of milrinone and epinephrine. And this is going to be added after you've volume resuscitated the patient, after you've given enough fluid to get the CVP or the RA pressure to, the mid-teens, certainly greater than the LA pressure. And in many cases, the surgeon has left an atrial communication. So they've left a PFO, or they have created a small ASD for you. So that will actually preserve cardiac output in the setting of RV dysfunction. And the patient will then shunt across the atrial septal defect or the PFO. So their saturations will be lower, sats in the 80s, for example, but their cardiac output will be maintained with that. So the cause of post-operative low cardiac output syndrome or low cardiac output in tetralogy patients is probably multifactorial. It can be related to their rhythm, to their residual lesions, or to RV dysfunction. So in summary, successful repair requires adequate relief of RV outflow tract obstruction, a good VSD closure, and minimizing residual lesions, and includes prompt recognition and response to low cardiac output secondary to arrhythmia, residual lesions, or RV dysfunction. Thank you very much for having me.
Great. Thank you, Jen. That was a great talk. And again, I want to echo Darren's comments about thanking all the speakers for taking their time, and of course, all the participants for taking your evenings and joining with us. We have a few questions from the audience. You can see them in the chat box, but I thought it might be a little bit better to have verbal response, and then we can have a discussion. So the first question from Vivienne is, thank you, Pooja, for a wonderful presentation. What would be the best bedside titration in a mechanically ventilated patient to ensure that one is ventilating around the FRC curve? So I see you wrote an answer, Pooja, but maybe if you can expound upon that and enlighten us.
No, this is perfect because as you see, there are many typos in this answer, so this is great. So depending on the mode of ventilation, SIMV pressure controlled or SIMV volume control. If you're on volume control, then you set the volumes as between 5 to 8 milliliters per kilo. If you're on pressure control, you set the peak inspiratory pressure or the delta P, but you need to watch for volumes. And what that is that's your variable, and that can vary from each respiratory cycle to the next one. So setting your ventilatory alarms to make sure that those volumes are not at the overexpansion curve, part of the curve, or under expansion, because if there is a patient with changing lung compliance because of either pulmonary volume, increased pulmonary blood flow, pleural effusion, pulmonary edema, those volumes can change. So assuring that the volumes are between 4 to 8 ml per kilo so that your overexpansion or underexpansion does not occur in whatever mode of ventilation you are in will give you that FRC, and that's where your PVR is the lowest. Barotrauma or volutrauma is also a risk, especially in patients who are going to need intubation for prolonged periods, where you can have pneumothoraces, etc., because of getting higher volumes. So hopefully that answers your question, Vivian. Happy to hear back if there's anything more you need answered.
Thanks, Pooja, for that answer. Vivian posted a second question as well, which we're going to direct to Andy, and it really involved about inotropic choices. And the question is, when initiating inotropic support to a child in low output who's already tachycardic from compensation, would your inotropic choice shy away from an agent that causes tachycardia, or that really won't matter as output improves and we expect the rate to drop?
Yeah, no, I think that's a
great
really
question.
Because I think that's something that we all struggle with, and I think this is under that category of there's no right way to do things, but there's certainly kind of wrong ways to do it. So I think for my approach, typically, if I have pressures that'll tolerate it, I prefer milrinone in those situations. Predominantly because it's not going to make you more tachycardic as a result of that. So if I can give you some afterload reduction and some modest inotropic support that way, that would be ideal. Certainly if you have pressures that are on the low side, then I try to creep in with some epi or dopamine, whichever. Usually for me it's epinephrine, but I usually start low and I watch what happens to the heart rate. And so I kind of titrate up based on how tachycardic the patient is getting. So certainly if I'm at 0.03 and the heart rate's the same, then I go to 0.04 or 0.05. And if the heart rate's still the same, then I call that success. But if I, get up to 0.05 and I try to creep up even more, and then all of a sudden the heart rate's 210, I'm probably hurting more than helping. And so then I kind of back off. You're correct that hopefully over time, then the heart rate actually will drop down as the inotropic state improves, although that's often somewhat delayed and not kind of an immediate effect of the medicines. So it is an ongoing balance between the two. And I think it's kind of a constant assessment between there and re-examination of what your medicines are doing for you.
Great, thank you, Andy. I don't see any questions at the moment. We're quite aware that it's getting late over in Africa, bedtime for all the kids, etc. But before we close, we wanted to invite our dear friend and close colleague and superb clinician, Dr. Nawathe, perhaps to just say a few words since we miss her beautiful voice over here. Can we unmute Dr. Nawathe so we can hear from her? There you go.
All right, thank you very much, Zahn. Thank you for the kind introduction. And thank you, MendingKids. Thank you, all the presenters. On behalf of the Jakaya Kikwete Cardiac Institute, whom we were all here, you could see our whole ICU team was here. We have Dr. Vivian from Israel. We have Dr. Stella joining us from Israel. We have Dr. Mbawala is joining us from Namibia. We have our Director of Nursing who is here. So everyone was here because this is very important. And we really appreciate this training from MendingKids because they are kind of tailored into the African content. Everyone is talking about the single ventricle repair, is talking about complex congenital heart disease. We're still doing the simple ones, and it's really important to learn from you all experts of what you've been seeing and what we can see once we're doing our simple operations still. So thank you very much for the others who are joining us. We've been with MendingKids for more than 5 years, where they've been visiting us and we've been doing operations. And during these missions, there's also some learning sessions which were going on. And due to COVID, we were worried that we will miss these learning sessions, but we're very happy that we are able to do it in this way. And we hope that it will continue. So the sessions have been very educative. I like the first session with the 10 commandments, and we've been evaluating ourselves on the WhatsApp chats, and there's a lot of things that we can do to improve from our side, and I think from other African countries who are doing surgeries. Thank you very much again, MendingKids, and thank you very much, Zahn.
Great. I see that our friends and colleagues in the Philippines, I think, win the award for staying up the latest. They're signing off now at 1:45 a.m. So look at that kind of dedication. It's amazing. Isabel, we leave the last word to you and MendingKids.
I just want to reiterate what everybody said. I want to thank everybody for taking the time to spend time with our doctors and be a part of this exchange for knowledge. On a technical side, we will be publishing this on our YouTube MendingKids channel. And for those of you who care to spend a few more minutes answering a questionnaire that we'll be emailing you, we'll be sending you some of the slides that the doctors are kindly providing you so you can have all that information. And really importantly, as we sort of navigate these sort of uncertain times until we can travel again, it's really important for us to hear from you what you think would be valuable, because we have certain ideas, and how that translates ultimately is if it matters to you. So please feel free to reach out to us, to our doctors, and we will hopefully be in touch with all of you very, very shortly. So thank you very much, and good night.
Right. Everybody stay safe. Thank you to all the speakers.
Thank
you all.
Yes, thank you
Bye.
so much to all the
Bye.
speakers. Absolutely. Bye.
Thank you.